Thank you for joining us for today's ASPPH Presents webinar, A Vision for the Acceleration of Global Health Data for Science and Policy, featuring Dr. Wilbert Van Panhouse, Assistant Professor of Epidemiology, University of Pittsburgh Graduate School of Public Health. This webinar is the fourth of the 2014 ASPPH Presents monthly series, which has been designed as a service to SEEP-accredited ASPPH member schools and programs of public health. A few housekeeping items of note: while you are in listen-only mode and your lines have been muted, we encourage you to ask questions throughout the presentation by using the chat or question box. We will address your questions at the end of the presentation. Please be sure to refrain from placing your line on hold during the webinar. Our speaker today, Dr. Van Panhouse, worked as a research fellow at the Center for Research on the Epidemiology of Disasters in Brussels and completed an internship at the WHO Western Pacific Regional Office in Manila, where he worked on dengue surveillance in the Mekong region. The research interests of Dr. Van Panhouse are infectious disease epidemiology and global health. In particular, the use of large-scale public health data for computational modeling and visualization of population-level disease patterns. Dr. Van Panhouse is also very interested in policy issues around the use and sharing of public health data for decision-making. Thank you for being here today, Dr. Van Panhouse.
Yes, thank you for giving me the opportunity to present to the association. I assume that the screen is now visible, the presentation?
Yes, looks great.
Okay. So I will talk about the vision of accelerating global health data for science and policy. This is work done by us at the University of Pittsburgh, funded by the Bill and Melinda Gates Foundation Vaccine Modeling Initiative, and also by the NIH MIDAS Consortium. So I'll discuss a little bit of a background about the current data in use and availability in global health. And so what's currently being done with public health data, and how available are global health data actually for the various uses that we have. Also, I'll tell you something about an example of making global health data available through our project TICO, and also talk a bit about our vision for advancing the use of data and the availability of data in global health in general. And so starting with why are we using data in public health, and I think everybody's probably well familiar with that, but just to reiterate, something that Alexander Langmuir said in 1963. Alexander Langmuir is the founder of kind of modern disease surveillance in the US, also of the CDC EIS program, and basically saying that that public health officials have to make very important decisions about interventions and programs that can affect millions of lives. And actually that's very acutely known today as we look at the Ebola crisis that's been addressed by public health agencies across the country. And so, but these decisions are not the responsibility of the epidemiologists or the public health scientists. It's really the job of us to bring the data and the facts to the decision makers so that they can make the best possible decision. And so throughout this presentation, it's really about how can we contribute to bring data to those decision makers so that the best public health policy can be made. And so here is one example. I give you a couple of examples of the value of data in public health. We may be well familiar with the value of data, but just to kind of formalize this a bit and say that especially high-resolution, large-scale data have been recently used for some pretty interesting things. And so here is, for example, the Malaria Atlas project run out of Oxford University, where they have used every single data point that they could find across the world on malaria prevalence, parasitemia. And so they've combined as much data as they could possibly find, thousands and thousands of records and data points and data sets, to come up with a global map of malaria endemicity. showing where does the malaria parasite occur in the world and where does it not occur. This includes these data points and also quite sophisticated spatial temporal models. But just to see that the combination of large-scale data from all these different surveys have helped to better understand where malaria occurs today. Secondly, a very well-known example of the Global Burden of Disease project run out of University of Washington, where also again data sets from tens of thousands of sources, surveys, vital registration systems, disease surveillance systems, hospital records, and many other sources are used to basically provide the best evidence that we have for the burden of disease and the distribution of the burden of disease by cause and by geography, age, gender, etc. And so this is another large-scale data project where data are being integrated from many places around the world to basically understand better what's happening. But not only at the global level, data are also extremely useful at the very local level. And here is a map of Oregon showing the exemption rates for vaccination at the county level. And so obviously county and especially state health departments would be very interested and to know where in their state the risk groups are for vaccine preventable diseases. And even at the county level, people want to know what schools are at high risk and which schools are not at high risk. And so even at the very local level, having detailed data about the status of interventions and about the status of health in the population can be extremely useful to make better public health programs. There is also a division we can make between historical and contemporary data, and these are two examples where on the left side there is the use of historical data going back to the 50s and 60s for pertussis in the US by state, and also comparing that to the recent patterns in the last decade. And so these large-scale, these historical data for all the states help us better understand what's happening currently with pertussis and the resurgence across the country. And so just to say that these data have value, even though you wouldn't expect maybe that data from half a century ago is still useful today, it can be helpful to look at patterns that occur today. And then also looking at the very contemporary part where there is real-time disease surveillance data here. This is an example from the UK where data are used on GP visits and emergency department visits and NHS records, actually showing day by day the number of cases related to heat stroke here to look at the effect of a heat wave. And also increasingly there are real-time disease surveillance systems where we can see directly what happens in an emergency rooms across a state or across a city to detect epidemics very early on. And so there is an extreme case of real-time disease surveillance, and also the very historical data can both be very useful in public health settings. Now, we know that all these data have such use and such value, and still major data gaps remain. We are definitely not there yet in terms of data access and usability. And so this is an example, an enlarged image from the Malaria Atlas project again, where you can see the locations of all these surveys. And basically showing large areas in Central Africa here and also in India where basically there are no surveys. And so models can be made, spatial models, to interpolate what's happening in these black areas from the survey points. But obviously there is large uncertainty, and especially for India that has led to very large differences between estimates in malaria burden from various groups. And so just to say that there is still an enormous lack in data collection in some parts of the world. But then on the bottom, the call from 8 global health agencies for more use of health data and more responsible use of health data, led by Margaret Chan, the Director General of the WHO at the time, really showing that there is a need for better use and availability of these global health data. And so here in Pittsburgh, we looked at, we did a systematic review in the literature to basically find out what are the various barriers that have been described that limit data availability and sharing. And so we found 20 unique barriers, and I'll just list here the 6 categories that we kind of created as a taxonomy to better understand why it is such a challenge to share and use data in public health, ranging from ethical barriers that have to do with just the lack of data collection, the lack of infrastructure, preservation, etc., but also motivational barriers, you know, the fear of criticism maybe to share data, the scientific credit issue, economical barriers that have to do with the cost of data sharing, potential economic damage if data are shared on disease outbreaks in countries, political barriers, legal barriers that are well known, and also ethical barriers that could limit data sharing. And the idea is that if we don't resolve some of these barriers, even though we can find technical solutions, for example, if we do not address the motivational, political, legal, etc., then data sharing will still remain very challenging. And so just to show an example of a technical barrier that we may all know very well is the format of the data. Here are some examples of our collaborations across the world. You can see here Niger, Africa, Laos, Vietnam. All these images show public health data, not always very long ago. And so Nigeria here is data from the early 2000s going into the 90s. Basically showing that the status of data preservation in public health is very concerning. And there are data disappearing every day because of these kind of issues. Not only in low-income countries, also high-income. Here is the Netherlands, a big city health department showing, this is an archive of data from about, I would say, 10 years ago. And here's the Pittsburgh Allegheny County Health Department, where you can see the status of data archiving. And so these are legacy data of observational records that cannot be replaced. And they are, they do contain valuable, highly disaggregated information about disease occurrence across space and time that could be very valuable for research and for policy making. But in the current status, they cannot be used. And so that led us to the development of kind of an idea about a global health data lifecycle. Basically, where you can see people get sick in a village, go to the clinic, data are born kind of as a clinical record. Public health agencies collect these or collect information, put it in a report, in an archive, a computer, aggregate, put the report somewhere else, make a nice annual summary report or something like that for the ministry, for the World Health Organization, and then data get destroyed. They get destroyed on purpose because of regulations, or they get destroyed accidentally because of fires, because of computer damage, because of theft, because of viruses, and a lot of other factors. And data, only a small fraction get used for analytics that will then go into policymakers' decision processes. So what we're trying to achieve is to kind of bend that curve up so that more and more data will go into the analytic phase after they have been collected as the routine function in a public health agency or in different agencies. And so this is another slide thinking about what is data in a usable format. Typically, for large-scale data use at the global level, but also at the local level, obviously access is one important issue. If data are locked behind lock and key, only very few people will be able to work on it and support the analytical process. And so the more open data are, the more people can work on it. Very simple concept, but very challenging implementation. Aggregation level is another dimension. Very low aggregation level contains the most information. Very high level aggregated data is often available, access level is typically very high, but the information content is very low. Think about, and I'll show you later examples, spatial resolution at the country level does not tell us anything about within-country disease transmission, and temporal resolution at the annual level doesn't tell us anything, for example, about disease seasonality. And so the lower the aggregation, typically the more use there is for data. And then the other dimension is computer readable. There is enormous amounts of public health data available, as I showed, in paper format or in PDF format or in other kinds of formats that are not computer readable. And so not having computer readable data in this day and age really limits the applications that, that can be made with data that's being collected. And so I'll just show you that most of the public health data, it's still very restricted access, low aggregation, but also low computer readability. There is some online data that's freely available, very open, highly computer readable, but very highly aggregated. And then there is examples such as the International Household Survey Network and GenBank and other formats that have very open access, aggregation is very low, and still also very computer readable. And so those are kind of our examples of data access. And so I'll talk to you a little bit about some examples of what can be done. Success stories kind of making data available. And so what would determine this availability, or what would be good models? And I've just put some characteristics here. Public data access at no cost typically. High spatial temporal resolution of the data. Data that are computer readable, that have extensive documentation about methodology that's been used to collect the data, integrated data that can be searched very easily across different data sources, and easy to use so that people can come along and actually be able to contribute to the analytical process without having to be an expert on the data. And so some examples are here, the Minnesota Population Center, the International Population Microdata, from censuses. They've done a phenomenal job in finding census data from across the world and releasing the microdata, all harmonized across time in common variables. The other one is the Household Survey, International Household Survey Network, that provides access to household survey data, also microdata from across the world. And so this is funded by the World Bank. And provides also very detailed public health data. And then our own Project TICO that we released last year. Currently, we made an update to version 1.1. That includes all the US weekly disease surveillance data over the last century. And I'll give you a kind of a run-through and an overview of that particular project as an example. And so Project TICO basically is access to public health data in a usable format, as I mentioned. It includes all US weekly provisional surveillance data since 1888, has 58 diseases under 27 years, 50 states, over 3,000 cities, and it took 200 million keystrokes to enter these data. All the data were entered twice for quality control. We have about 1,400 users of the website and the interface. People have to register for free, but we do track people's use. So and have kind of some kind of evidence of the user base, many web visitors, page views, and data downloads. And so we really hope that making these data available like this will help encourage the use of global health data like this. And so then overview, we took all these unusable data from PDF, paper copies, HTML files that could not be downloaded, and we basically standardized these data into a database that now can be used for analysis. Why TICO? This is named after Tycho Brahe, a Danish nobleman who made extremely detailed observations about positions of stars and planets. And Tycho did not want to use his data for a particular type of analysis that Johannes Kepler wanted to do. And after Tycho died, Kepler used his data to derive the current laws of planetary motion. The idea here is that Kepler made this huge breakthrough discovery while Tycho did not have that vision. And so our project does not claim to make all the discoveries ourselves, but we just kind of provide the data so that other people can come by, just like Johannes Kepler, and use the data to find new discoveries, gain insight in disease processes and other things. Obviously, we also contribute to the analysis ourselves, but it's not our main goal. And so here's some digitization, really to show that this is manual data entry. There was no possibility with this large data set that's very changing over time to do optical character recognition. And so this was done by a company, a social venture, Digital Divide Data, that employed people, students in Cambodia and Laos, to do half-time data entry and also half-time university education. So the company provided these students with education opportunities as well as jobs. And so going to, was digitization necessary for this data set? Yes. Just to show that PDF documents for various journals and reports were available on PubMed Central, also on CDC, STACS, Centers for Disease Control, and HathiTrust, which is a digital library. And current data since '96 are on the MMWR archive. And so one long historical data set has been split over a variety of repositories and locations in a variety of formats that make it very difficult to use as one data set. And so we did integrate and digitize this data set. And here you can see one of the very old tables where there are some cities listed, including Philadelphia, Baltimore, New Orleans, the week of the report, and then for a variety of diseases, cholera, yellow fever, etc., the number of deaths reported. This is in 1888, just when the system started up, and it's progressed extensively since then. This is a more common report in 94, 95 here, January, showing the states listed with all the diseases that have been reported over time. And so just as a terminology, we call these numbers reported a count. So if you look at the content of the data, here are the numbers of counts, the number of data points reported by year from the beginning of the system until the current. And this shows the geographical granularity. So first there are data at the city level, in blue here, a little bit of data at the county level, but then the city level data increased because more and more cities were included in the system, and then states were introduced, state level data reporting, and then the cities kind of dwindled away until the CDC took over the system in the 50s from the Public Health Service and implemented state reporting only. And so the number of reports here is increasing for all the states because more and more diseases are added to the system. And so before 1950 there is predominantly city level reporting, and after 1950 there is predominantly state level reporting. Another split is between morbidity versus mortality. And so again, the number of counts, the same number of counts per year, but now indicated by mortality reports in orange, and in blue the case reports, the morbidity reports. Just to show that in the very beginning there were mortality reports only, up to today when the large majority of data are case reports, not death reports. Death reports for infectious diseases are, for example, available through the death certificate data, not through the regular disease surveillance system here in the US. And so most of the data overall is case-based, and we have actually very few death records except for a few diseases here before the 50s. Another feature is the subcategories of diseases. Here's a good example of hepatitis, where you can see all the different types of hepatitis that have been reported over the last 120 years or so. And you can see it begins as a combined report of infectious and serum hepatitis, and then slowly more and more different subcategories are used as more and more becomes known about hepatitis. And I've put this up to really kind of show the complexity of standardizing these data, because to use these data in long time series, we have to harmonize the subcategories used in, for example, the 80s with the subcategories in the 60s to kind of glue them together. And so serum hepatitis represents hepatitis B, and infectious hepatitis, hepatitis A. But then there are all kinds of subcodes like hepatitis C, non-A, non-B, or viral type unspecified. And so it'll become very complex to find out exactly what is contained in those categories and harmonize them with the other categories. And so that's work that's still ongoing. So the application, one of the things that we did is to show the history of disease reporting in the US. Here in this graph you can see the very beginning of the system in 1888 and the progression through the decades with every concentric circle going from 1910, 2030, etc. to 2010. And so it shows for each of these diseases the number of deaths reported in red, or not the number of deaths actually, but whether there was a death report or not in these years. And so this just shows whether a disease was reported at all by health authorities or not. In red it shows death reporting, in color it shows case reporting. And so you can see typhoid fever, for example, has been reported at the weekly intervals since the early 1900s to the 2000s and not afterwards. So very recently it was taken out of the weekly notifiable disease system. The different colors indicate how many subcategories were reported. So black is just one subcategory, like for mumps here. But then again for hepatitis you can see the large variety of subcategories that have been reported. And it basically shows how the time series is broken up in pieces that cannot necessarily be used together as one. And so the more homogeneous the color, the more continuous the time series is for the disease. You can also see that early on there were a variety of diseases, and then as time progressed, more diseases got added to the system. And very interestingly, for example, very recently here, the Legionella was added to the system in the early 1980s when the Legionella outbreak occurred in Philadelphia. And the AIDS outbreak started also in the 80s and was added to the system, just as like Lyme disease. And so there are some really interesting historical public health features into this data set. This is another display that shows the progression of a disease through time and space. Horizontally you can see the different states listed, and vertically the weeks. And so each vertical bar is 1 week. You can see how thin they are because there's many weeks in this x-axis. And the combined numbers for the whole country are listed above here. So you can see the very characteristic annual and multi-annual measles patterns of going throughout the US and the state-specific patterns in color coding here with high incidence rates in red and low incidence rates in blue. And you can see the annual epidemics occur in most of the states at the same time. And this big red line shows the year of vaccine introduction, in 1963. And so after 1963, the disease disappeared from the US quite rapidly, going from all these red colors to this blue color. And so in a few years after vaccine licensure across the country, the disease disappeared, showing very clearly the impact of a vaccine program throughout a country. And this is for pertussis, a similar graph showing the pre-vaccine rates here, very high in red and yellow, and post-vaccine introduction, the disappearance of this disease for a long time, until recently. And so if you kind of enlarge this a bit, you can see since the 90s up to the 2010, the resurgence of pertussis throughout the country, in particular in some regions of the country, here already 2004, and then later throughout the country, the emergence again of pertussis even during the vaccination program. And so that was the case in the release paper of this project when we described the effect of vaccination programs in the United States, estimating roughly that about 100 million cases of 7 childhood diseases have been prevented in the US by vaccination. And we used the pre-vaccine and the post-vaccine licensure data to make these estimates. We also released at this time the full data set to the public through a web interface. And so now I'll give you a quick tour, demonstration of the website, so that you can see kind of what it looks like. And I think this should be visible to everybody. And so this is the home page, and there is 3 levels of data that we're making available. There are kind of 3 levels of quality of data. Level 1 data show the data that we used in the release paper. And so these data have been tailored specifically to this analysis, including, for example, imputations of missing data, including standardizations of various subcategories of diseases, etc. And so if people want to replicate the analysis or have a clean data set to use, they can go right here and use data for these diseases. Obviously, there are a few number of diseases because cleaning has not been completed for all of these. There is extensive data availability, exploration tools, and search and retrieve data tools that I'll demonstrate in level 2 data. And so here's level 2 data, version 1.1.0, and here it shows very quickly, in quick overview, what the data we have available. And so this shows the number of counts, number of data points in thousands for these diseases. So they include the number of data point, number of weeks, as well as the number of locations that report this data. Here is the state level data, and here is the city level data. Blue is the counts that are not 0, and red are reports of 0 cases. So for poliomyelitis here you can see there is 26,000 or so counts of 0. And we make that distinction because in a lot of analyses it's not so interesting to look at large time series of zeros. But you can see for the city level data here and for smallpox at the state level we have mostly zeros, obviously because the disease was eradicated. And so for many diseases there's only very few data points available just because they were very recently introduced or very shortly reported. And then we have the same kind of display for the mortality reports. And you can see that at the state level we only have mortality for pneumonia and influenza combined, which is a specific part of the current surveillance system. At city level we have many more death reports, mortality reports for a variety of diseases. And so there is a data exploration tool that you can use to find out if we have data on something or not. And so we do require registration and acceptance of a Creative Commons attribution license. And then you can explore the data. So for example, you can explore data by disease, whether you want to explore cases or deaths, also whether you want to look at the city or the state level. So if I click state level here, for example, and suppose I want to look at hepatitis A data, you click on submit, and here you have all the different states, and it shows from the very early 1966 how many records, how many counts there are for this particular state. And so that basically represents the number of weeks, and you would expect 52 reports for every year. In this case you have 50 reports for 1966, which is fairly complete. The lighter the color, the more incomplete the data. And so here for Alaska, for example, you can see 22 weeks for 1967, or even for 1980, 14 weeks. And then at this point in 1988, there is no data at all until the current times for this state. And so the availability of data varies tremendously by disease and also by location, just because the reporting system had so many differences. So you can click on the Get It button here and just get the data for a certain state. It shows a display of hepatitis cases by week for this time series. It also shows an Excel download link as well as a table. And the table is interesting because for all the different weekly reports, it also makes a link to the original source PDF. So if you click on this PDF, for example, it will bring you to the original report here where you can download the original data to look at. There's also a search and retrieve system where you can make very detailed queries about the data. And for example, if you're interested in city level data, cases for measles in Pennsylvania, you can click a couple of cities like Pittsburgh and Philadelphia, add them to the list, You can also vary the time period of interest and the output format. If I submit this query, it will generate graphs to look at as well as the table of the data to download. And so this is kind of a clickable interface where you can explore and use the data, but there's also an API connection that allows investigators or others to use a computer program to query the database. And so, for example, a variety of statistical packages allow direct querying of databases through an API connection, so that you don't have to click your way through the data, but you can just automatically let the computer search for it. Then there's level 3 data. Level 3 data are all the data we have, has not been cleaned yet. Level 2 data are actually filtered data that are all consistent with each other. And so they can be used without much cleaning to basically just display time series and compare time series to each other, etc. But level 3 data is everything we have, including a large number of subcategories that have not been standardized yet, and other types of data, all kinds of counts. And we have a request form for this. Just because we don't encourage the use of these data without extensive cleaning, and also because the database is quite large, so people can select here what type of data they're interested in, and then they will get it, and also we'll have to then do a significant amount of data standardization and cleaning before they can be used. For example, you can see here for measles there is locations. It includes the option unspecified locations, which are records for which we could not identify the reporting location. And so again, that will take quite some cleaning, going back to the source reports maybe to try and find out what the exact values were of some of the data. Then there is an extensive resources page that gives you all kinds of information about the use of the data, as well as tutorials and audiovisual information, also some computer code. And so we try to track what people are doing and adding to this repository so other people can benefit from what's already been done. So going back to the presentation, so that's kind of an overview of the data repository in Project TICO. What are the user groups that we're looking at? Mostly scientists that want to look at historical disease patterns, look at the impact of interventions, look at forecasting maybe, students for all kinds of theses and practicums, policymakers that can use this to look at their own state, at other states, comparing the patterns across locations, etc. Industry, media, general public. There's a large variety of groups that could be interested in this. It's been kind of another angle to this is the Open Government Initiative in the US that aims to unlock governmental data for innovative use. And so this project was featured by the Secretary at the time of Health and Human Services as an example of unlocking CDC data on contagious diseases. And so it's exactly what was mentioned earlier on, trying to make public health data available in a usable format. Infographics is another application that's been done here to kind of educate people and for advocacy about vaccines. And so here you can see the different vaccines introduced, and some of the diseases, pertussis or hepatitis A here, did not decrease as much as some of the other diseases such as measles, mumps, rubella. That was the message of this one. And then there's been also some very innovative data mining work done. So the applications are not only from public health, but also from other groups that here have an automated system to detect patterns in longitudinal time series data that was used as well. And so there is this use now, but now is the question where to go with this. How can we use this and extend this to advance really the use and the availability of data in global health? So the next step for our project is to, for example, include other data sets. And so there is almost for every disease a variety of locations across the globe where data are stored that are not put together in some reasonable way for use. And so one of the next steps that we are doing, just because we have an interest in dengue, we are working on combining dengue data from a variety of online sources, countries that put PDF bulletins online, as well as, for example, here Brazil has an extensive database that's open access for 6,000 municipalities that's very undiscovered. WHO obviously has databases online, a variety. And so what we're trying to do is combine all these different repositories and data into one dengue integrated data repository to again advance the use of these data in public health. Another one, so we work on a variety of projects, but this is just another example of US vaccination data. And so this came out of an interest looking at the impact of vaccination to see if we can find the data on vaccine coverage. And this actually is data from 2010 or 11 showing the highest resolution that we were able to find by looking online as well as contacting every state health department. The highest resolution data that could be made available to look at vaccine coverage. And so as you can see, for many of the states, the highest resolution was the state level. And for many other states, the highest resolution was the county level. And for California, actually, the highest resolution is the school level. And so these are just as an illustration of how granularity is relevant for policymakers as well as scientists, because obviously at the county level, the risk areas for disease outbreaks are much more clearly visible than at the state level. These large state level averages obscure a variety of heterogeneities inside the state that are really not helping to identify risk areas and study the link of vaccination coverage with disease resurgence. And so we're trying to make these data available in due time and at the same time advocating for the availability of more granular data for this particular vaccine coverage data. And so then going towards the vision of where all this should go, looking at database linking. And so one of the examples is that instead of trying to make a very massive, large repository that includes all the data that we can find, it is a lot easier nowadays to use the internet and make database connections. Just like the API that I just discussed, we set up a system where we connected our own database in the US with similar databases in France and in Taiwan, just through our personal collaborations, and then making a demo where we can query France, US, and Taiwan at the same time, and generating these time series of mumps in Paris, Washington, and Taipei that can be displayed all at once. And so that's kind of a mini example of where things could go, combining a large number of databases across the world into a network rather than large-scale repositories. And so going into the vision of where this could go and how this could scale up potentially, thinking about a large number of locked-up data sets in various places. So this represents government, for example, academic centers, and businesses and commercial companies that all have locked up data repositories that are not available to anybody else. And there is a need to kind of for these data sets to be linked into a data network that can then be used interactively. And so a data network here, this is just an example of the web of data, can include a variety of data sets. And I just kind of indicated here in red that not all the data sets need to be fully open access. There's definitely probably part of the solution to make some of the data sets restricted access for good reasons such as legal issues or privacy issues. But then at least they're still part of the system so that when access is granted, they can be searched together with all these other databases at once without having to do massive amounts of data integration, cleaning, standardization, etc. That work will already have been done. And so standardization, anonymization of private data, for example, data rescue is the rescue of paper-based data or antiquated electronic data that can be included, documentation, etc. A lot of kind of tasks that need to be done to bring data from the locked up areas into a data network that's mostly accessible to everybody. And so the roles of schools of public health, thinking about the Association of Schools of Public Health, is kind of multifaceted. Schools of public health are part already of the academic community, and so many schools of public health do have data repositories already, including us here at Pittsburgh. And so work needs to be done to kind of bring these data out, and is being done, into the public domain, into the network of databases. Public health schools also have the connections to the government agencies as well as a lot of corporations, and can kind of use their influence to bring about these data sets as well. And then there is the functions that will facilitate the process of unlocking data, such as capacity building in data management, in data processing, etc., and the use of data in analytics, advocacy for the use and the value of public health data, building infrastructure to facilitate unlocking of data, and governance, trying to find out management structures and support structures that will actually advance the use of public health data for science and policy. And so those are just a few ideas of where schools of public health could contribute. And so very practically, what needs to be done is integration of new data, includes data rescue from paper integrated databases, linking of existing databases. A lot needs to be done to kind of set up these systems, standardization of data, for example, looking at ICD standards, looking at the names of locations. Tremendous work remains to be done in using standard names for locations, linking metadata about data collection and data annotation to the data points themselves. As I said, develop infrastructure and quality control, and also data analysis. The more data used in innovative ways, the more they will demonstrate the value, and the more data will become available for global health. And advocacy, as I said before. So these are just some ideas of how this can move forward, what's required. These are the acknowledgements. This is a large team here at Pittsburgh trying to look at making examples of unlocking the data just with Project GECO. We're also looking at the larger scale policy perspectives of what facilitates data access and use in public health. So that concludes the presentation, and I'll hand control back to the moderator.
Thank you, Dr. Van Panhouse. As a reminder, at this point, all participants are welcome to submit questions via the questions box. And you can find the questions box by clicking on that little arrow. And we do have a few minutes left for questions. To kind of kick off the conversation, wanted to start off with a discussion about public health data to be available. We do need protocols to encourage local and global governments to share data and to ensure the confidentiality of the data usage. And wondering if there are any standardized protocols to ensure public health data sharing, and kind of as a subset of that question, how could these protocols and perhaps even something like the Project GECO model be adapted in low resource settings?
Yeah, thank you. Regarding the protocols for public health data, depends a little bit on the data type, but there's really not much available. There are protocols, for example, data sharing guidelines or data sharing regulations in health agencies or other places that for their own institution regulate how data are being shared. But at an international level, there is actually very little guidance for agencies to kind of work their way towards an open data structure. It's not clear for agencies where to go, who to ask for help, etc. So there is a need for governance, for guidelines, for treaties, for systems to kind of facilitate the data sharing. This has been done partly for vital statistics. Many vital registration systems and vital statistics, there is the United Nations Statistics Office that provides guidelines on how to kind of best practices for sharing and collecting vital statistics data, but that has not really been generalized to other data sets yet. And then for low-income settings, there is obviously an interesting dichotomy where countries with low incomes and kind of bad quality data, many data gaps, also have the highest disease burdens. And a lot of how this can be transported, I guess there's quite some work needed to do capacity building, to do training, and also to do data rescue. And a lot of the photos I showed are from low-income countries that have the paper-based reporting systems. There's also a lot of large variety of new electronic systems provided by a variety of donor organizations. But the focus has not been on data sharing. The focus has been largely on data quality of the data reporting. But there would really be great benefits to also look at the sharing and the availability of these data so that the whole global community can help advance the use, the analytics, the insight that these data can provide. Obviously, again, there is a need for strong international governance to facilitate that data are shared equally and equitable and with reciprocity for data providers in low-income countries. So there's really a great role there for international organizations such as the World Health Organization or other UN organizations to help countries facilitate data sharing.
Great, thank you very much. The next question coming in relates to, you did show a brief slide about some of the users that are registered to use the Project TICO data, and wondering if you have any examples of how the data have been used and specifically to influence policymakers.
Yeah, so actually we do request that people that use the data will let us know so that we can kind of advocate their types of use. But since the year that's been applied, that the data have been released, there have been a few studies, like I said, the data mining study, our own study, but there have not been studies yet published that really influence policy making using these data. And so I know of a variety of groups that are working currently and submitting their projects to journals, and so I think over the next 6 to 12 months there'll be a lot coming out of work that has been using these data in the same line of work as, for example, that pertussis paper I showed, looking at the 1950s and the current resurgence. There's a variety of pertussis papers in the making, a variety of measles papers, mostly through our own collaborators that knew of these data right when they came available. And so one of the kind of things to do is to try to make people aware of the resource as much as possible so that the data can be used by as broad an audience as possible to influence decision making. But currently there are no clear examples yet, but I think time will tell us how useful it will be.
Excellent, thank you. I have a question here about specifically related to institutional review boards, and it's saying that an ongoing issue for IRBs in considering domestic human subject protocols relates to assessing current standard of care, and of course the challenges of these assessments in an international arena, and especially in the developing world, are even greater. I'm wondering if you could discuss whether accelerated global health data sharing might be able to assist IRBs in making such determinations in a more ethical and accurate manner.
Yeah, I think that's correct. I think depending a little bit how quality of care will be measured, but for example, looking at generalized health outcomes such as morbidity or mortality, if these data would be available, especially at the granular local levels, then it would become more clear, especially if there's interventions being planned, how these interventions would impact quality of care and access to care. Would really looking at pre-intervention, post-intervention data, looking at the spatial distribution of health outcomes, can be related to quality of care and can then also be used by institutional review boards. And I would think that the more available the data are, the more they can be used like that by institutional review, and also the more open they are, the more transparent those kind of assessments can be made. And I would think that transparency would also increase the ethical basis of it, but I'm not very sure about that. But I do think that, yeah, especially the health outcomes, if that's kind of the metric for quality of care and access to care, then that becoming available would really help. And that's another reason why, for example, we're looking at hospitals and hospital systems that have a responsibility for quality of care in their own populations, that can actually contribute to a data system like this. But that's kind of very young still, and hopefully that will develop in the next years or so.
Thank you. And it looks like we have time for just one more question, and I'd like to close actually with a question here specifically about Project TICO, and wondering if you have any plans to standardize the level 3 data that you mentioned, and what the process for that would be.
Yeah, thanks. That's a great question, actually. We do continue. So the database is continuously in flux, and actually for the most recent update, we moved quite a lot of data from level 3 to level 2 because we could standardize the subcategories. For example, hepatitis A and hepatitis B have been added to level 2 now, and measles more recently has been added to level 2, as well as polio. And the reason they were not in level 2 before was because there were all these subcategories that first needed to be standardized. And so we will continue here in Pittsburgh the standardization of level 3 data so that they can move to level 2 and be used more widely. However, there is a lot of work to be done. Quite a lot of records are still in level 3, and so we have to pick and choose what has the priority. And we'd welcome, of course, any partners that would be interested in contributing. We hope in the end that this will become a community-based process that many people can contribute to this, although it will take a significant amount of research and interest to do this. But yeah, we are continuing this, and over time more and more records will move from level 3 to level 2.
Excellent, thank you. And it looks like we have run out of time. So I would like to thank everybody for joining us today for this excellent presentation, and especially thank you to Dr. Van Panhouse for providing this information for us today. For those of you on the line who still have additional questions, please contact ASPPH with any additional questions that you may have. And this does conclude our webinar for today. Please stay tuned for the next ASPPH Presents webinar on our website. Thank you.